hospitals in general are self-funded employers, meaning that they're already at economic risk for the healthcare costs of their employees. And so every effort they put into managing those costs will be returned to them. It's not shared savings, it's 100% savings. So we think that's a great place to begin to implement some of the care management changes like the patient-centered medical home, chronic disease management programs. And we see hospitals all over the country doing it in our collaborative, in the premier collaborative that we work with, that have begun to do that. And there's some real models out there. Places like Heartland Health in St. Joe, Missouri, they've done a great job in that area already. Central Maine Healthcare in Lewiston, Maine. They have an arrangement with Bath Iron Works where they've reached out and they have a shared savings agreement. So it wasn't initiated by an insurer, it was really initiated by a self-funded employer. And we think that that's a good place to start in a lot of communities, because if you think about it, a lot of the hospital board members are part of companies that would be very interested in shared savings. And the old model isn't working. And so people are interested, what can we do differently? What can we do to incentivize people? And I really do believe that we have to tie the economic incentive with the behavior we want. And I use the diabetic as a great example of that. That in the old fee-for-service world, hospitals and doctors got paid more when the diabetic has a complication. In this new world of accountable care, you'll get paid more when you keep the diabetic healthy, out of the ER, out of the hospital, with their hemoglobin A1C below 7. That's what we believe it makes more sense than this system of paying more for complications. We actually try to help them think through how to manage it so that we align it together, align the care management changes at the same time you're changing your payer model. Because I've worked with one hospital in Michigan, for example, that did a great job of changing their care management program with patient-centered medical homes and chronic disease management program. But it was a financial disaster for them because they were paid fee-for-service. And they had a drop in ER visits, a drop in medical admissions, and it was a financial disaster. Nobody was paying for that infrastructure. So our advice is you've got to move to a model that has like a care management payment, a shared savings component, and what we're seeing in a number of markets where the major insurer is actually giving a block grant for funding that transformational cost. So we're seeing all three: the block grant, the care management payment, and the shared savings. The early adopters, Banner Health, they're beginning to see fairly dramatic reductions in costs and use. And I think as that spreads throughout the country, I think you're going to see this grow. And it is growing. I mean, the number of organizations that are putting shared savings in, both on the private side and now on the Medicare side, is increasing dramatically this summer. And we expect that to continue.